malignancies. We know that there are many immune checkpoint inhibitor combinations out there that are safe and effective. The most, more effective ones are with chemotherapy, particularly in non-small cell lung cancer, as well as VEGF TKIs. But despite, our attempts at, finding good predictive biomarkers and finding effective combination regimens, the majority of patients still lack durable responses. And, a lot of efforts taking place in understanding why that is. So, the question is, what stress got to do with it? So there's been a lot of work that's been done looking at the relationship between stress and the immune system over the last 35 and 40 years. In fact, there's a field called psychoneuroimmunology that's exploring this. And mainly stress is coordinated with two pathways. First one being the hypothalamic pituitary adrenal axis, which releases glucocorticoid hormones as the main stress hormones, but also it releases norepinephrine and epinephrine from the adrenals. And then the second pathway is the sympathetic nervous system, and it's coordinated via the adrenergic receptors. And this is important because our lymph node systems are heavily innervated with the sympathetic nervous system, and nearly all of the immune cells that are in our body have adrenergic receptors on them. So, we know that acute stress may heighten your immune system where more immune cells are released into your circulation. But we also know that chronic stress over a long period of time is immunosuppressive. And this relationship has been explored more closely in how it relates to cancer. And this review paper released about a couple of years ago highlighted some of the different mechanisms of how this happens. So norepinephrine is the main neurotransmitter in the sympathetic nervous system that is implicated in this. And mainly it coordinates activity in the tumor cells as well as the microenvironment that consists of inflammatory cells, endothelial cells, other lymphatic cells, fibroblasts, and as you can see, there are multiple ways that it leads to cancer progression, some of them more directly affecting immune cells. And so the thought is, can we potentially block the activity of norepinephrine with beta blockers? We know a lot about beta blockers for decades now, mainly in cardiovascular disease and anxiety. We know that they're safe and potentially could be a good option to augment the activity anti-tumor immune response. So there have been observational studies looking at beta blockers in cancer, and no trials have been successful, but a lot of observational studies in various solid tumor types have shown that potentially the addition of beta blockers is beneficial in reducing cancer-related mortality. And not going to go through each one, but you can see that there's a large body of observational study evidence that shows this relationship. And particularly, they looked, in this review, they also separated propranolol versus other beta blockers. This is important in that beta adrenergic receptors, there's beta 1, beta 2, and we don't quite know what the role of each of them is in coordinating and modulating the immune system. So much of the preclinical work we know about adrenergic signaling, how it relates to immune response in leading to anti-tumor immune response. And there's a group at Roswell Park that published this paper 3 years ago. And what they did is gave different stress conditions. So one of the stress conditions was mice in colder temperatures, 22 degrees Celsius, and then they took away the stress with beta blockers to see if that made any difference. And You can see that the mice were treated in 2 separate conditions. They gave propranolol starting 4 days before, and then they followed them. They looked at 2 different mice, B16 ova, which is a aggressive melanoma, xenograft, as well as 4T1, which is a aggressive breast cancer, mammary cancer. And in this C here, what it shows is that when you have a stressed environment at 22 degrees Celsius without any addition of beta blockers, the tumor grows fairly rapidly. But then when you take that away with the beta blocker, or you take away the low temperature, the tumor growth is reduced. And this was shown again in the other xenograft model. And also very similarly, it showed in when you silence the adrenergic pathway, this effect is also seen. So the next question was, why does this happen? What is the mechanism of how adrenergic signaling leads to anti-tumor response? And they explored the immune system. And first, they looked at immunodeficient mice and seeing if there was any difference if you took away the stress with beta blockers or a higher temperature. And there was no difference. So potentially this is all coordinated by the immune system. And then they looked more closely whether this was a CD8 T cell mediated mechanism. And in fact, it was. So, if you look at, the propranolol group or the control group, when you take away the CD8 cells, the tumor grows fairly rapidly. But then when you when you give back the CD8 T cell activity, the propranolol group had the best outcomes in reducing the tumor growth. And again, this was shown in the other xenograft, and then this was shown also when they silenced the adrenergic signaling pathway. So we know that it's a T cell mediated mechanism. And they also looked at, in the tumor microenvironment, what happens to the frequency of the tumor infiltrating lymphocytes, as well as the functional activity of them. And what they found is that the number of lymphocytes that enter the tumor don't change with beta blockers. But what happens is it alters the function of them, where some of the more effector signatures, such as TBET, which is a transcription factor that increases effector molecules like IFN gamma and granzyme B, is increased. IFN gamma levels are also increased. Interestingly, granzyme B levels were about the same, but the intensity in those that expressed granzyme B were increased. In addition, they also showed that the number of immunosuppressive cells, T regulatory cells, as well as MDSCs in the spleen were altered. And this potentially, is multifaceted, CD8 T cell driven, but it could also affect the immunosuppressive cells, and that's how we're getting the anti-tumor immune responses. And then finally, they looked at whether if you combine beta blockers with anti-PD-1 blockers, is that better than just giving anti-PD-1 checkpoint inhibitors alone? And yes, that is true, that the tumor growth is reduced further when you give the combination as opposed to single agent. So the only clinical data that existed looking at this combination prior to us looking at it was in metastatic melanoma. And it's the same group that looked at this, 195 patients that had metastatic melanoma. They were treated with immunotherapy. The one caveat to this is they not only looked at immune checkpoint inhibitors, but they also looked at IL-2 in a 15-year span. And there was actually a dramatic difference. They looked at pan beta blockers, so beta 1 and beta 2 blockers combined against beta 1 selective blockers. That didn't show any difference. And then when they combined pan beta blockers versus beta 1 selective or no beta blockers at all, again, then they saw the effect. And it was a dramatic effect, 70% 5-year overall survival versus 25%, in a fairly decent sample size. So this group actually is doing a clinical trial now looking at pembrolizumab and beta blockers, propranolol specifically, in metastatic melanoma. So when we went back to our database to study this combination, we ended up finding 339 patients that were treated between 2010 and 2017 that received at least 2 doses of immune checkpoint inhibitors that had diagnosis of various advanced solid tumors. And in our cohort, 109 of those had were actively on beta blockers. 25 of them pan beta blockers versus 84 beta 1 selective. And the control group had 230 patients. And we were interested in looking at multiple clinical endpoints, and primary one being disease control rate. We define this as, any patient that's not progressing, so stable disease and above, and over the total cohort. We also looked at duration of response. We defined this as duration of therapy. We felt that was the closest thing we could find, given we don't have RECIST criteria for patients that we see in clinic routinely. And lastly, we also looked at overall survival. We compared the disease control rate between these two groups using log regression. We looked at duration of response using ANCOVA regression and overall survival using multiple methods, Kaplan-Meier method, looking at median overall survival, and then Cox regression. So looking at the baseline characteristic of our cohort, it was balanced, in some regards, but there were some differences. So the beta blocker group tend to be older, which was statistically significant. They tend to have more cardiac comorbidities and CKD. And they had a higher frequency of former smoking history as well, and a higher BMI, median BMI. We looked at demographics. I didn't show it here, but they were balanced between the two groups. Importantly, the performance status were similar between the two groups, as well as the line of therapy that these patients were on, the percentage of patients that were on first-line therapy. And this is just a snapshot of the different tumor types that were part of this database. The most common, 4 common types of malignancies were most common being non-small cell lung cancer, then melanoma, and HCC and urothelial carcinoma. But we had 27 different tumor types in total that were part of this cohort. So looking at the outcomes of our study, the disease control rate, the beta blocker group had a significantly higher disease control rate, 63% versus 38%. I apologize, I forgot to include the confidence interval for this. But when we adjusted for age, performance status, BMI, and line of therapy, this relationship and this difference was statistically significant. And we also looked at duration of response. And again, after adjusting for these factors, the differences were statistically significant. So looking at the overall survival analysis, this Kaplan-Meier shows our cohort in 3 separate populations: the beta 1 selective in green, the non-selective beta blockers in blue, and in black, and the control group, no beta blockers, in blue. And we looked at median overall survival. We calculated that, and this log rank p-value shows comparison between beta blocker versus no beta blocker, and that was not significant, so we didn't separate it further. When we looked at hazard ratios using Cox regression, beta blocker versus no beta blocker, hazard ratio was 0.83, but it was not statistically significant. when we broke it down further, looking at pan beta blockers versus no beta blockers, again, there was no statistical difference. And then when we looked at just beta 1 blocker, the hazard ratio was the best one, 0.72, and was close to being statistically significant and trending, but the p-value was about 0.05. So, what conclusions can we draw from this is, the preclinical evidence and the other retrospective cohort and our data shows that this reduced adrenergic signaling may, in fact, have some modulation of the immune system via CD8 T cells in driving this anti-tumor response. Our data does show that the beta blocker addition may improve immune checkpoint inhibitor activity, although the overall survival, there was no difference. Some of the limitations in our study is the sample size in the treatment group was fairly small. It was imbalanced towards the control group. The other one is that it's a heterogeneous population. We looked at all tumor types. We're actually working on analyzing the subgroups of the 4 common tumor types separately, which we'll have soon. But a larger data set in a homogeneous tumor type would be more reassuring to understand this relationship. And ultimately, we want to do a prospective clinical trial looking at this combination and doing correlative science to see if we can correlate adrenergic activity within the tumor with immune response. So that's it. I want to thank our program directors, Dr. Malone, Dr. Kozic, for supporting us through these 3 years and hammering us about these presentations, and hopefully have improved over time. And I want to thank the GU group, particularly Dr. Sao. He came up with this idea and did a lot of the literature search early on, and push us to get the database going and refined and to do this analysis. So, especially want to thank him. I want to thank Dr. Galsky, Dr. O, for supporting me through this project and also other projects over the last few years. And there's a large IO database team here that's headed by Amanda Leiter. She's an endocrine fellow graduating now. And also some of our co-fellows, Janie, Bo, Tommy, who worked on this with us. So I want to thank them as well. And then finally, our co-fellows for great 3 years. And we'll see you guys, more on the other side as an attending next year. But it's been a pleasure, sharing the fellowship with you guys. So any questions?
But I think that was excellent, and I think it's very, very, it's a very important aspect of oncology, and I think it deserves further evaluation.
Okay. If no questions, we can hand it over, or John, if you're not, I think I finished a little early, so
Can you
can
hear
take
me?
a break. Yep.
Should I start now or wait? Whatever.
John, if you think, I think it's always, I don't know. Let me see the gallery. How many? We have a pretty full quorum here.
Okay.
So I think it's fine to start, especially if you're concerned you're either going to go over or there might be a vigorous Q&A.
Hopefully it won't go over. All right, I'll start sharing my screen. All right. Hi, everyone. I'm going to be talking about MDS and the immune microenvironment. Kind of affected by coronavirus, but we'll talk about that. These are my disclosures. And so this is the slide I took from my last talk discussing luspatercept, and just wanted to emphasize how little progress we've made in MDS in terms of new therapeutics in the last few years. We did finally just get luspatercept approved just a few months ago. But if you can see here, FDA-approved treatments, there's only 5 for MDS, and then you can also include erythropoietin stimulating agents, ESAs, and there's just been very little progress made in the last 10 to 15 years. For patients who have failed a hypomethylating agent, there are no treatments, and so we have still a long ways to go to improve treatments in MDS, and so hopefully we'll be discussing new potential treatments today. And just a brief overview of my talk. We'll discuss immune dysregulation in MDS, an exciting translational research project that we just started. And then we'll discuss T-cell abnormalities and the use of IVIG in MDS. And then finally, we'll discuss some clinical trials that we've been working on in the MDS group. And so the innate immune system is known to be dysregulated in MDS. It's thought that chronic inflammation can lead to the development of MDS, and it's known that there's a significant increase in autoimmune diseases in patients with MDS compared to the normal population. We've seen that many MDS patients have overexpression of immune-related genes, and pro-inflammatory cytokines are upregulated in MDS and are thought to be extremely important in contributing to ineffective hematopoiesis in MDS. And then toll-like receptors, which are known to be one of the most important parts of innate immune signaling, are overexpressed in MDS hematopoietic stem cells. And then just as a disease model for understanding how the innate immune system works in MDS, deletion 5q MDS, which is a haploinsufficiency, when we look at patients with this specific syndrome, they were able to show beautifully how microRNAs and other proteins that are on the 5q chromosome can lead to innate immune signaling and progression of disease. So this is just a nice little schematic. You could see here that the toll-like receptor is able to receive ligands, and then once it's activated, it signals through MyD88 and IRAX, eventually to TRAF6, and then leads to further signaling. Important parts here is that the microRNAs in green and TIFAB, which is another protein, these are actually on the 5q chromosome, and when they're lost, it leads to upregulation of these other factors in red, which lead to overstimulation of the immune system. And then another key important part is the inflammasome, which I'll mention several times throughout the talk, NLRP3. This leads to pyroptosis, which is another form of cell death, a little bit different than apoptosis. And so we saw before that S100A8 and S100A9, the alarmins, they're endogenous ligands for TLR4, and they can activate myeloid-derived suppressor cells, MDSCs, which then start this autocrine signaling feedback loop with the alarmins to increase innate immune signaling and inflammation. And then they activate NLRP3 inflammasome, leading to pyroptosis, which is one of the sources for ineffective hematopoiesis. And then it could also induce reactive oxygen species and PD-1, PD-L1 expression as well. And again, just another schematic showing the activation of the innate immune system. It's just a pretty picture. And you could see the inflammasome activation as well here, and the interaction of the alarmins with TLR4 and the inflammasome. And then just as a side point, CHIP mutations are also thought to work through activation of the NLRP3 inflammasome, at least some of them, including TET2. And this is thought to be the source of increased cardiovascular risk and is of interest in clinical trials. Now, in terms of the adaptive immune system, adaptive immunity is also dysregulated in MDS. This is a little bit more, this part of the research is a little bit conflicting and not as set in stone, but it's known that CD8 cells are higher and Tregs are lower in lower risk, and then the opposite is true in higher risk MDS. NK cells have been found to be lower in CD8 cells as well. CD34 positive blasts have higher PD-L1 expression. And clonality in MDS has also been seen in both the T cells, different T cell populations, and with progression to AML. And then of note is that azacitidine is thought to recapitulate a normal immune phenotype when comparing patients who have and haven't received azacitidine. So this led to some translational research project that we're doing with Dr. Silverman and the Human Immune Monitoring Corps. And so some of this research was already started by Dr. Biggenwald and was presented at ASH this past year. So in collaboration with the Human Immune Monitoring Corps, able to show that NK and gamma delta T cells are increased and B cells are decreased in the bone marrow of 33 MDS patients versus healthy controls. I'll show the data in a second. This was all done via CyTOF mass cytometry experiments, and also able to show that in the T cell compartment, there's an increase in Tregs and an exhaustion-like phenotype of CD8 positive T cells in MDS patients. And then using O-leak proteomics, able to show that there's an aberrant corresponding cytokine signature in MDS patients as well, which I'll show in a few slides. And what's notable is that this study, I think, from what I can tell, is the first CyTOF-based study looking at the whole immune landscape in MDS. Some previous CyTOF studies have been done just looking at the hematopoietic stem cell compartment. But the goal here was really to use the power of CyTOF and mass cytometry to take a global look at the immune landscape in MDS. And so this is just some of the data that they were able to gather. Over here are the myeloid and lymphoid panels of antibodies that were used to identify these cells. So you can see it's just a really powerful way of being able to look at a ton of different cells and gather a lot of data just at once in one big experiment. And you can see here, NK cells, gamma delta T cells are increased. You would think this would lead to a pro-inflammatory environment, but consequently, Tregs are also increased, which would be the reverse. We don't know if these are, Tregs are increased because these are increased. We're just not entirely sure to counterbalance. And then B cells, on the other hand, are lower, which is kind of, and this data supports some of the earlier studies that have been done in MDS. And then this is O-leak proteomics looking at the serum of patients, corresponding patients of MDS patients versus healthy controls. And we could see here that, we haven't, this is just preliminary data, but we haven't been able to delve into it, but these are our healthy controls. And you could see here, it looks like these patients have an increase in apoptosis and lymphocyte crosstalk signaling, while over here, chemokines and MMPs are lower in these patients. And so been working with Dr. Horowitz and PhD student Forum Patel from the Tisch Cancer Institute, and our goals are really to bring these studies forward. And so what we're going to be doing is we're going to be looking at more CyTOF studies and matching the data from patients from their bone marrows to peripheral blood samples. And then also our goal is to look at more O-link data. We want to look at both the bone marrow supernatant and peripheral blood serum. And then further, we're going to integrate some of this clinical data and some of this with clinical data and try and see if we can show any correlation between clinical outcomes and the immune landscape. And then lastly, what we're going to be doing is we have a lot of samples in our biobank, and we're going to be looking at sequential time points of these patients and tracking to see how the immune landscape changes as patients progress with MDS, if they respond to treatment with azacitidine or other treatments, and if they progress to AML. And so we want to see how the immune landscape changes at different time points. And so just next, I'll be just going through just briefly a retrospective study we did with Dr. Silverman that we presented at ASH last year. And so it's known, as we talked about, that there's aberrant autoimmune diseases in MDS, and it is increased, patients with MDS are at increased risk of autoimmune hemolytic anemia and ITP. And it's also known at the same time that patients with MDS can have co-occurrent clonal T cell populations and even LGL leukemia. And so Dr. Silverman had this idea to use IVIG, which is known to be anti-inflammatory and can directly inhibit T cells, as a way to see if we can control these T cell populations and stop these autoimmune phenomena. Now, what's important is that we don't think they're B cell related because they're Coombs negative, and these patients all have TCR gene rearrangements, or they have expanded T cell clonal populations by flow cytometry. So what we did was we looked at 27 patients, 22 of whom had MDS. And what we did was we gave them IVIG, 500 mg per kg weekly, and then we would taper IVIG as tolerated. We would also include a steroid burst for most of these patients if they can tolerate it, and try and quickly wean the steroids as well. And so our goal with this was to try and see if we could control autoimmune cytopenias just with IVIG alone, which would help mediate hematopoiesis and improve blood counts in these patients in a novel way that is not very toxic and extremely well tolerated. So this is just some of the baseline data. We had 27 patients. Median and average duration of treatment was 5 and 16 months. 74% of patients had concurrent steroids. And you could see here, looking at some of the baseline values of these patients, median, for example, median retic count was 3.5. Most of our MDS patients have very low retic count. So these are obviously patients where something is going on. They have elevated LDH, and over 40% of patients have an undetectable haptoglobin. And then in terms of baseline mutations, we could see here that they're pretty representative of an MDS sample. A lot of P50, most represent TP53, ASXL1, and SETBP1. And then 24 out of 27 patients were TCR beta positive rearrangement. And then we had some expansion of LGL and K-like T cell populations by flow. And then this is just a brief look at some of our outcomes data that we have. In terms of responses, we were able to have an overall response rate for cytopenias of around 80%. This included around 60% for patients with their red cells and 30% in the platelet line, and almost 50% in the neutrophil line as well, although this one we always take with a grain of salt because these patients, a lot of them were getting steroids. And then we came up with this hemolytic response criteria. A complete response was when patients would achieve normalization of the corresponding lab value, and then a partial response was when they would get below 50%, at least 50% improvement from their baseline in terms of their hemolytic parameters. And you can see here that for each lab value, there was mostly between a 30 to 40% improvement in these markers as well. And this was done in all 27 patients. In the 22 specific MDS patients, you could see that the response rates were quite similar. And then in terms of overall survival, median overall survival was 42 months for this patient population. And we had really excellent survival from patients who responded versus those that didn't respond, though these are small patient samples, so take it with a grain of salt. And then obviously can't give a talk without a Kaplan-Meier curve here. And so this is just overall survival stratified by IVIG response. You can see it's significant in terms of the improvement in responders in green versus non-responders. And so with our IVIG data, we're hoping to expand our patient population, look at more patients that we're treating with this. And then also we want to work with Dr. Horowitz again and Forum in looking at specific immune landscape parameters with similar studies that we did before with Cytofa, potentially with Olink. And then also we are working with Dr. Holdsworth with TCR-seq data in terms of looking at how TCR-seq impacts some of these patients. And it's some exciting data, hopefully, to present in a manuscript soon. And then finally, I'll talk about just a couple of clinical trials that we're interested in. And so I specifically got interested in the SYK pathway, which is potentially a novel way that we could use to manipulate the immune landscape in terms of treatment. And so the SYK pathway is part of the family of B-cell receptor-associated kinases. It's highly expressed on all hematopoietic cells and is extremely important in adaptive immunity signaling. And so we could see here that SYK in green is attached to many of these cell receptors. So you have the T cell receptor from T cells, you have the FC receptor from macrophages, and a B cell receptor, you have SYK associated as well. And once the parent receptor is activated by its ligand, SYK is phosphorylated and leads to signal transduction via ITAMs. And SYK then directly interacts with a host of other pathways, including MEK, ERK, AKT, NF-kappa B, mTOR, and NIP. And then this is just a pretty picture showing SYK signaling in more detail. You have the receptor that it's attached to and associated with ITAMs, and then the phosphorylation cascade. These are the direct binding partners of SYK, and then the proteins and signaling intermediates it interacts with, and then the cellular responses that it leads to. And then over here, we have our old friend, the NLRP3 inflammasome, which is also another reason why I got very interested in it. And then once innate immune signaling happens through these CLECs that SYK is associated with, you can have NLRP3 inflammasome activation via ROS. And then you also can have NF-kappa B activation as well. And so SYK not only plays a key role in adaptive immunity, but in innate immunity as well, as we just saw with the CLECs and the inflammasome activation. It's active in neutrophils, macrophages. It's responsible for phagocytosis, mast cells, and NK cells. And it leads to ROS production, cytokine production, and immune cell proliferation. So I'll just talk about two quick trials that we're in discussions with now that involve SYK inhibitors. They both have been impacted by coronavirus, so hopefully we can get funding and start them up as soon as possible. So the first one is the use of fostamatinib, which goes by Tavalisse. It's FDA approved as a second-line treatment in chronic ITP. It's also the only FDA-approved SYK inhibitor at the moment, and is the reason how I got interested in this when I was looking up after Tavalisse got approved and its unique mechanism of action. And so we're in active discussions with Rigel, which is the pharmaceutical company responsible for Tavalisse, to try and secure funding for this trial. We plan to recruit 16 lower risk MDS patients, and our plan is to use it in the patient population that received IVIG, and I'll show you in a second the schematic for the trial. And we also would hope to do some correlative lab studies looking at the immune environment of fostamatinib. So the film trial, this is the study design. It's for lower risk MDS patients who have cytopenia, and then also have a T cell clonality identified via flow cytometry or TCR gene rearrangement studies. Important is that Tavalisse can cause hypertension, so we want to make sure that their blood pressure is well controlled. And then we're trying to avoid patients who've had some TPO agonist as well. And so the first part would be an accelerated titration design just to make sure that Tavalisse is tolerated in MDS patients, because sometimes they have difficulty tolerating new drugs that haven't been tried in them. And so our plan is to just quickly see if it's tolerated, and if so, then we would do an expansion in 12 patients at the highest tolerated recommended phase 2 dosing and look at further endpoints of efficacy. And I just wanted to thank Dr. Doroshow and the chiefs. They were helpful in Dr. Doroshow's Veil-like clinical trial design. I was working on this with her, and she was very helpful. And then another trial with SYK inhibitor called this one Attack Farm trial. So this is using TAK-659, which is a dual SYK FLT3 inhibitor. It's previously been trialed in relapsed refractory AML as monotherapy and other heme malignancies and solid tumors. Unfortunately, had minimal efficacy there, but that was just as monotherapy. Our goal here is to combine it with pevonedistat and AZA. I'll show the study design in a second. So just a little background, pevonedistat PIVO, it's an experimental NET-A activating enzyme inhibitor. And so the NET-A pathway works with, is part of the ubiquitin proteasome pathway, which works in protein degradation. And it has very promising results in combination with azacitidine in higher risk MDS patients in AML. It's currently in phase 2, phase 3 trials, and it likely will be approved. There's a strong chance it will get approved next year in MDS. And then why we think that they might work together. So the netylation, PIVO is thought to be an NF-kappa B inhibitor because the netylation pathway is important in the NF-kappa B activation pathway. And so our thought is that combining PIVO and an SYK inhibitor might have some increased synergy. We saw that SYK inhibitors can inhibit the NF-kappa B pathway. And then there's this increased thought about synergy with MCL1 downregulation, and MCL1 is important in pro-apoptosis pathways. So we're in active discussions with Takeda, which is the pharmaceutical company behind TAK-659 and pevonedistat, regarding funding opportunities for this trial, and also, again, impacted by COVID-19, but hopefully we are able to secure funding soon. So we plan to recruit 30 patients in higher risk relapse refractory MDS, which is a patient population where there is no currently FDA approved drugs. So this would have a similar study design as before. So first we would start with an accelerated titration design, just make sure that TAK-659 oral therapy is tolerated in MDS patients, which we would expect because it was well tolerated in patients with AML. And then assuming there are no dose-limiting toxicities, we would proceed to a standard 3+3, looking at the combination of TAK-659 with standard dosing of PIVO and azacitidine at increasing dose levels. And then we would expand it out with an expansion cohort of 15 patients for a total of 21 patients to look at overall response rate and different endpoints. And we would also do correlative laboratory studies as well. And then I guess I have a couple extra minutes, so I'll just quickly talk about this before ending. So in terms of immunotherapy in MDS, PD-L1 is thought to be a mechanism of HMA resistance. It's upregulated once patients receive HMAs. And so the thought was, oh, why don't we add in a checkpoint inhibitor like we do with every other cancer and see if that works. And so both PD-1, PD-L1, and CTLA-4 checkpoint inhibitors have been trialed in MDS and AML. Overall, the responses haven't been amazing. As monotherapy, they don't seem to have much efficacy. There have been combinations with azacitidine, including Nivo and Nivo plus Ipi in the treatment-naive setting, which have been a little bit more promising, but this is all mostly from MD Anderson in terms of the exciting data, so we have to take it grain of salt. And then I think why that's true is because this large azacitidine plus or minus durvalumab, randomized phase 3 trial was just presented at ASH this last year. And unfortunately, it was a negative trial in comparing patients with or without durvalumab in treatment-naive higher risk MDS and AML. It didn't really show a difference in survival or response rates. And so other checkpoint inhibitors, TIM3, which is also a checkpoint inhibitor, it's been used in combination with this inhibitor called MBG453 with decitabine. It was also recently presented at ASH last year, showing some improvement over decitabine, but again, not amazing improvement. It's in early phase trials. But definitely the most exciting one is the CD47 inhibitor magrolimab. CD47 is a don't eat me signal on macrophages, and actually showed great efficacy data, including in the TP53 population in early phase trials. And so with that, and also magrolimab hopefully will start enrolling patients here at Mount Sinai soon. And so this was just this was actually the first trial that we worked on in the MDS group in trying to secure funding. So far, we haven't been successful, but we're hopeful that we will be able to soon. So this is the use of azacitidine with rigosertib and nivolumab. And so rigosertib, which is a RAS mimetic, and small molecule that's able to inhibit multiple pathways. The sequence of rigosertib followed by aza has been shown, Dr. Navada and Dr. Silverman have shown that there are great responses in patients who have failed HMA, and it's thought to be upregulation of interferon and RIG-I pathways, which might correlate with azacitidine. So azacitidine is known to increase the expression of ERVs and CTAs, endogenous retrovirus and cancer testis antigens, and it's thought to activate interferon signaling that way as well. So the theory is that the combination would upregulate interferon signaling, and then by adding in nivolumab, we can increase T cell activation and increase the potency of this drug. And notably, none of the drugs have overlapping toxicities, so we think that the combination will be well tolerated. We already have buy-in from Onconova, but we're just awaiting support from BMS, which now has both AZA and Anivo. And then this is just like a brief mention about it, and then Dr. Bala will soon, I think, be mentioning more about rigosertib and nivolumab in lung cancer in the near future. And so these are just future directions of our research plans. So as we talked about, want to perform more translational lab work to try and further the immune landscape profile in terms of effector cells and cytokines in treatment-naive patients that we're already working on. And then we'll expand that to look at different sequential bone marrow and peripheral blood samples as patients progress and relapse. And then expansion of our IVIG cohort and correlative lab studies, and including the use of TCR-seq. And then most importantly is funding for clinical trials that we've been working on. So these are the learning points I hope you take away from the talk about the importance of the innate and adaptive immunity dysregulation in MDS, how much more work there is to be done in profiling the immune landscape in MDS, how IVIG is a potential option for MDS patients with T-cell clones and autoimmune cytopenias, and manipulating the immune landscape as a novel therapeutic strategy, and just tried to give a little overview of different areas that I've been working on and will be working on in the future. And just wanted to give a thank you to everyone, Dr. Silver, Dr. Navada, and Aaron from the MDS clinical team, and then Dr. Horowitz and Forum, who we just started working with closely together and hope to have a bunch of exciting new lab work, and then Camille, Dr. Biggenwald, Dr. Ryan, Dr. Melina, who worked with Dr. Silverman, the Immune Monitoring Core and Dr. Silverman's lab, and then obviously Dr. Malone, Dr. Kozak, and my co-fellows. And just reason why, these are the reasons why I haven't slept. Very, very adorable, but don't like to sleep at night. And with that, I'll take any questions. Thank you.
Hey, John, this is Sangeeta.
Oh, hi.
Hi. Cool concept and a great presentation. I might have missed it. What is the primary endpoint in the Tavalis trial?
So that one, it was just, we were looking at, it was just a little phase 1b, so looking at overall response rates and then improvements in hematopoiesis in both the red cell and the platelet compartment.
Okay. So are you going to exclude TP53 mutated MDS patients or del5q or SF3B1?
I don't think so. You know, this is just, it's all preliminary, so we haven't gotten down to the nitty gritty yet in terms of mutations. I don't know. I don't think we would exclude those patients. In terms of SF3B1, I guess with luspatercept now approved, that throws a little wrench into it.
Yeah.
But for the other patients, I don't think we would exclude.
Because del5q isolated or low risk del5q already has lenalidomide. So would you think about including them, or?
I think if we wouldn't, I don't think we would take patients who are eligible for lenalidomide, but if they've already progressed after lenalidomide, I think it would be okay to take them. You know, I obviously haven't fully, you know, gotten down the exclusion and inclusion criteria yet, but it's something we'll talk about.
Thanks,
That's a
John.
great idea. Thanks.
John, thank you. It was just a really masterful presentation where you really walked through the data. The style of speaking and the slides were excellent. So congratulations.
Thank you. All right, I guess there's no